afternoon. This is Dr. John Bennett of Neurosurgical TV here in sunny Miami Beach. Under the quarantine, pretty strict. Today we have the pleasure of having Ashish Tandon, MD. He's a neurosurgeon from India who's done a fellowship, I guess, with Charles Teo in Australia, I understand. And he'll tell you some more maybe about his history. We'll introduce the panelists later. Okay, it's all yours, Ashish, and welcome.
Okay, thank you so much, John, for the invitation. So, good evening, friends, and thank you for joining us for this interesting webinar on management of complex thoracolumbar kyphotic deformity, osteotomy, and PVCR technique. To briefly introduce myself, I'm a neurosurgeon practicing in the central part of India, and I love operating on complex spine, CVJ, deformities, tumors, etc. My main inclination is trying to get all these procedures with a MIS approach. However, I must truly confess that as far as deformity correction is concerned, perhaps I do all my procedures through an open approach. Okay. Now, how come neurosurgeons and deformity correction, they have stayed away from each other? And one important reason for that is poor understanding of the issues of spinal balance. So that has been a very important reason. Also, we did not have the adequate exposure to deformity corrections when we were in training. So that is another reason why neurosurgeons traditionally have stayed away from deformity correction. I'll just quickly show you one case here. This gentleman is a 35-year-old male. He has progressive kyphotic deformity, and this is really severe kyphosis. He has been suffering from severe back pain and pain in the flanks and progressively increasing weakness over the last 1 year or so. He tried to get some form of treatment or the other, but eventually he became bedridden. And he has been bedridden for 3 months. So that was the first case. And, as soon as we see that case, we feel that, what we need to do. And we push them to dedicated deformity surgeons, which I don't feel is correct, because we have been operating port spine and infection-related problems for more than 4 to 5 decades now. So what is the reason to jump to, or why do I want people to get into deformity? The reason is that we are treating the whole of spine, from craniovertebral junction to L5-S1 listhesis to sacral problems. And also I feel that mere neurological improvement of the patient is not the final goal. It is not the complete treatment. And correction of balance of that patient should be given its due importance, because it improves the quality of life and there is decreased pain reduction. So we are used to listening that after surgery, my radicular pain has gone, but the back pain is there. And we generally don't give a lot of thought to that. Similarly, we have been operated for the neck, myelopathy has improved a lot, but the neck pain persists and we don't even think a lot about it. So it is now time that we put one step ahead. So the same patient, this patient which I was discussing has a motor power of 1/5, and he has severe Not only kyphosis, which I showed you, he also has a scoliotic deformity. So now I want to bring the concept both of coronal instability as well as the sagittal imbalance. Now you look at this patient's MRI and you will see that, you know, there is some sort of recurrence of his original disease in here. There's a lot of infiltration and still there is a lot of compression, and that has perhaps aggravated his situation over the last few months. Now, when we are treating such a patient, what sort of questions should come to our mind? The first is, whether do I offer surgical treatment or not? Whether do I offer a correction maneuver or not? And then if I do, what would be the prognosis in such a situation? What are the levels and types of osteotomy? Now, this word osteotomy, again, you know, sort of pushes the neurosurgeons away from deformity correction. And this is just another word like laminectomy. So one does not need to worry about such vocabulary jugglery, I feel. And then what is the degree of correction we want to achieve? And especially in thoracolumbar and lumbar areas, how to tackle the lumbar roots while negotiating the cage. Because these days now, the era is of a total posterior approach. So I'll be talking about all this. Now, this is another case which we very, very frequently come across. She is a lady in her 7th decade of life, persistent severe back pain with claudication. There's been failure of conservative treatment and various blocks, etc. Now, as soon as we see this, we feel that, you know, look, there is scoli in this patient, and we all know that this is degenerative scoliosis with a lot of osteoporosis. What we forget is to notice that there is severe loss of lordosis and a kyphotic spine. Now, degen scoli, if you correct the scoliosis, the patient is not going to be relieved of her symptoms. You need to correct the sagittal imbalance, which is, in other words, you need to correct the kyphosis of the patient. Now, in this patient, the challenges are entirely different vis-a-vis the challenges which we faced in the previous case. Here, age, obviously, she is in her 7th decade, severity of scoliosis, there is a lot of osteoporosis, and there is lower inflection point. The inflection point is the point where the lordosis is getting converted into the kyphotic. So that inflection point has come really down. So we need to consider that as well. John, am I audible and like, is everything okay?
Yes, perfect,
Hello?
perfect, perfect.
Okay, okay, fine. Now, let's see what is the basics of spinal balance. Now, anyone, if you feel that there's something which I have not been able to make simple, or if you have not understood, please note it down and we'll try to come back to those basics of spinal balance. Though I have tried to make it as simple and as clear as possible. Now, there was this efficiency conus postulated by Dubouset and his team. And to simplify this, let's consider pelvis just as a single block of bone. Similarly, we consider head as a single block of bone. Okay, and both of these sort of are connected with each other through spine. And there are curvatures of the spine in such a fashion that you have maximum efficiency, and your center of gravity is through this central cone. Now, as you move away from this cone towards the larger cone, there is a lot of inefficiency in your balance. Okay, and this is merely what we need to correct. That's it. So the whole thing about spinal balance is to bring this patient head to this central conus. Okay, so let's consider pelvis as one block and the head as another, and they've been aligned to each other. Now, to simplify again, as far as sagittal balance is concerned, all of you please remember that the most important line that we need to draw is the C7 plumb line. Now, what is this line? C7 plumb line is a line that is drawn vertically down from the center of the body of C7 and goes up to the sacrum. Now, usually what happens is, in a sagittally balanced patient, this line comes near the posterior superior border of S1. 0.5 centimeters of here and there is normal. However, the deformity surgeons have given 5 times more leverage, and if this plumb line is 2.5 centimeter here or here, then you consider this patient as a sagittally imbalanced patient. So if this line goes towards the body, it is a positive plumb line, and when it goes behind, it is a negative plumb line. The thoracic kyphosis is around 10 to 40 degrees, okay? And lumbar lordosis is between 40 to 60 degrees. Now, why do we have thoracic kyphosis just from T4 to T12 and not from T1 to T12? And the reason for that is, all these measurements are done on long x-rays, on full length x-rays from the shoulder as high in the cervical spine to the hips to see the femur heads. Okay. Now, when you take that x-ray, the T1 to T3 area is usually hidden by the shoulders. And that is why most of the measurements are done T4 or downwards. So I hope I've made this clear. Now, as I told you, Dubouset and his theory is that, you know, let's consider pelvis as the first vertebra of the whole spine. Okay. And so if this is the pelvis, the whole spine is standing here. Now, just consider, if you are considering this pelvis as one vertebra, then it is very easy to understand what is retroversion and what is anteversion. Okay. So we don't need to get confused in pelvic incidence, sacral slope, you know, that can come later. What you need to understand is, like you know about the lumbar and cervical and thoracic spine, what is retro and anteversion, just consider something similar for the pelvis as well. So as I have told you, sagittal imbalance is when you have a positive or a negative plumb line. So the line which we draw is 2.5 centimeters anterior to the S1. Now, basically, I don't know whether I'll be able to show you or not. So suppose if I'm standing like this, the plumb line is going to go anterior if I like sort of bend forward, you know, my posture becomes like this. This will throw the plumb line anterior. And when I'm a little too lordotic, it's going to go behind. Negative plumb lines are not very common, extremely rare. And now what happens when the plumb line goes anterior? The muscles in the back, accessory muscles, try to pull back the head, you know, and that is where the muscles fatigue after a certain point of time, and the patient develops pain. Okay, so this is very, very important to understand, not just for the patient, but also for us as surgeons or as human beings as we are aging. Now look what happens, how the compensatory mechanisms work. In the beginning, you have the degeneration of the lumbar spine. Now, as the lumbar spine degenerates, there is loss of lordosis. Now, once you have loss of lordosis, there is reduction in the kyphosis as well. Now, to balance this, the pelvis needs to go behind. It gets sort of retroverted. Now, look here. if this is the normal pelvis and this is the femur, when the pelvis goes behind, it retroverts, there is hyperextension of the hip. Now, once you have hyperextension of the hip to compensate that, ultimately you have knee flexion and hyperlordosis of the neck. So these are the various compensatory mechanisms. And this all we see in an elderly patient. Okay, so just see how it sort of becomes flat back, then he starts stooping in front, and as he starts stooping, his knees get flexed, and you know, to maintain his vision, straight vision, he needs to sort of keep his neck, you know, straightened or hyperlordotic. So these are the compensatory mechanisms. Now, why I am telling you all this is because though it has an indirect bearing to correction of kyphotic deformities, but you should know all these basics, that why we are doing or what is the end result of our correction. Now, as I have already shown you that thoracic kyphosis is measured from T4 to T12, and it is usually 0.75 times the lordoting angle. So we saw that the lordoting angle is higher. Now, after a certain point of time of trying to understand the spinal balance, you need to know these three very important pelvic indices: the pelvic incidence, the pelvic tilt, and the sacral slope. So the sacral slope is the easiest to understand. There is one transverse or parallel line parallel to the ground, and you make a line which is parallel to the end plate, and this angle is the sacral slope. Pelvic tilt is from the center of the S1 vertebra and to the femoral head, and you draw a straight vertical line, and this is the pelvic tilt. So these two combined form pelvic incidence. Basically, this will help us understand the angles for a particular human being. Usually the PI is fixed, and it may be unique as well. So there is nothing right PI or a wrong PI. So now I hope I have sort of tried to simplify things as well as far as spinal balance is concerned, and you know what are the factors playing into it. Now let's focus. So we have two different entities. One is coronal imbalance, which is scoli, and one is sagittal imbalance, which is kyphosis. Now kyphosis or hyperlordosis. Now you just have to remember that it's extremely rare to just have one entity at a time. You generally, the coronal and sagittal imbalance, you find them in most of the patients together, and you need to sort of treat both of them together. But to make things simple, apart from one or two cases, I'll try to show you cases where there is exclusive kyphosis and that how to correct that kyphosis. Now, sagittal imbalance is generally, obviously, we all understand that it is secondary to some underlying pathology. One of the commonest is degenerative disc disease, where there is loss of lumbar lordosis. And then the patient sort of to compensate, and then there is overcompensation and things like that, finally leads in some patients lead to thoracic and dorsolumbar kyphotic deformities. Then you have pot spine and infection. I've kept it a little higher because in India and perhaps in Africa as well, the cases would be many more. Then neglected trauma, malignancies, osteoporotic fractures, angst-pond, iatrogenic. So we ourselves have led to a lot of flat back leading to the sagittal imbalance. Now let's focus on pot spine for a few minutes. Now, what are the surgical indications in pot spine? The first and foremost is progressive neurological deficit. Okay, I'm just talking of pot spine. I'm not talking of any deformity right now. when do you try to operate in port spine? So if your patient is developing progressive neurological deficit, if he is also developing progressive spinal deformity attack, okay, then if there is a failure of conservative treatment, operate. Then if you're not sure of the diagnosis, ideally I should have kept this on top, because now we know that it is incorrect, improper to treat a patient conservatively or whichever way without a diagnosis. So you need to have a culture or a biopsy or whatever to ascertain the diagnosis. And then lastly, severe secondary pain in view of the abscess or instability. So those were in any port spine. Now let's see what is post-tubercular kyphosis and how sort of it develops. So as we all know, initially you have the paradiscal inflammation, which weakens the vertebral end plate. And this leads to the loss of anterior vertebral column height, and eventually you develop a kyphotic deformity. Now in adults, this is important. In adults treated conservatively, there can be a 15-degree increase in kyphosis. Okay, so you need to measure it right now, and if you're treating the patient conservatively over a period of 6 to 9 months to a year, the kyphotic angle or the Cobb's angle would increase by 15 degrees. Out of them, 5% of them eventually will have a deformity more than 60 degrees, and that is where sort of any deformity more than 40, 50, 60 degrees, you need to jump in. Okay. The situation is very different as far as children are concerned. Here, there is higher risk of developing kyphosis. The cartilaginous vertebral body is prone to destruction with continued growth of unaffected posterior column. Now, when you start treating deformity, you will read something about crankshaft phenomena, wherein you are fixing the posterior part and the anterior part is growing. So this is something similar in concept, but here the reverse is happening. The anterior column is getting affected more, and the posterior is not that much affected. So ultimately, it leads to kyphotic deformity. Here, in almost 10% of patients, the kyphotic deformity would be more than 90 degrees. So what I'm trying to emphasize here is act a little faster in pediatric patients. Okay. Now, why do we have kyphotic deformity, which are more difficult and more severe in children? One, because in patients less than 7 years, the anterior body collapse and the growth is very, very different and fast. After that, or after adolescence sets in, especially in females of 10 to 11 and males of 11 to 13 years, this growth difference is not that much. Secondly, thoracolumbar involvement, and if there is loss of more than 2 vertebral bodies, which you may have a higher frequency amongst children. So once we know, once we have focused a bit on infection and POTS, let's see what are the aims of the surgery that we would be undertaking. So first and foremost, obviously, is to achieve balance. Okay. So as we had discussed that cone, we try to bring as near to the center as possible. Now, again, a word of caution here. Please try and understand that when you are correcting any deformity, be it scoli, be it kyphosis, you need to look at the flexibility of the spine and how much is required, because at one point of time, you will start injuring the neurology. Okay, so we don't need to make him absolutely straight, or we just need to make him cosmetically better, neurologically well preserved, and his deformity should not increase. Second, we relieve the pain. Third, we need to prevent the recurrence or worsening of the deformity. And obviously, this is always in our minds to improve the neurology as much as is possible. So how to achieve balance? Okay, we have various osteotomies. I'll just show you three important osteotomies, and I'll try to simplify them, okay, so that there is no confusion and you can use it very, very easily. And after you have achieved osteotomies, you go in for reconstruction and fusion, okay. So what are the available approaches that we have? Like for any spine condition, say trauma or infection, you have an anterior approach, anterolateral approach here. Then you have combined anterior and posterior approach. And then you have the posterior only approach or 3-column osteotomy and correction. To briefly summarize the next few slides, this is what is being undertaken these days, and this is the most popular. Fine. So now anterior is effective in resolving the neurological deficit, but it may not help in correcting the kyphosis to that extent. Okay. Combined anterior posterior approach, the problem is that you will have a higher complication rate. Okay. Mind you, many of these patients, because of their kyphotic posture, scoliotic posture, their lung compliance is not very good. Okay, so when you're doing anterior and posterior, the lung related complications, the time, overall infection, pseudoarthrosis may increase. Then the next approach, which is a very simple approach, and you know, this is sort of I must say your escape route is internal kyphectomy. So when the patient is coming with paraplegia to you, and you know, you feel that he has some bowel bladder remaining, or you just want that his symptoms should not progress, then you can do an internal kyphectomy. Or whenever you feel that correction, it is too rigid, too big a curve, and correction will lead to further neurological deficit, then you can go ahead and do an internal kyphectomy. So the word in itself means that you cut the kyphus to relieve the neurological pressure. Now, posterior only approach, it helps us with the current technology that we have, the current instrumentation that we have. It enables both anterior decompression as well as posterior fixation. Okay, the correction of kyphosis can be achieved from 40 to 80 degrees approximately, which is a very, very good margin. The lower complication rate also because we are too used to, we are doing this posterior approach day in, day out. And the posterior only approach has been helped by neuromonitoring as well. Okay, so the shortening that you can achieve of the cord or of the nerves is much higher once you have the neuromonitoring. And again, I must tell you that please do not undertake complex kyphotic or scoliotic corrections without neuromonitoring. Okay, so but again, it may be difficult for all the centers to have that. So I would say that you correct, but don't correct very severe deformities. Fine. And if you do not have an intraoperative neuromonitoring, then you should definitely explain this to the patient. So in the ideal world, all complex scoli and kyphotic corrections should be under neuromonitoring. Now coming to the osteotomy. Hello, John.
Yes.
Is everything okay till now?
Yes.
Okay, fine. So I'll keep on moving ahead.
Okay.
Okay, fine. Now, types of osteotomy, we have the Smith-Peterson osteotomy, the Ponte osteotomy, pedicle substraction osteotomy, and the posterior vertebral column resection, which is the most popular, though most challenging as well, but the results are great as far as correction is concerned. Now, these red, I mark these red because I would be discussing these in a little more detail. So Ponte osteotomy was basically just a step ahead of the Smith-Peterson. It was described by Alberto Ponte in 1987 for Schumann's disease. And this is a pure posterior column osteotomy. Okay. Now, what is a posterior column osteotomy? It is just simple. You are removing all the ligaments from a particular level. So supraspinous, intraspinous, then ligamentum flavum, and part of the joint. So that area becomes free, the roots are free. That is what is Ponte Osteotomy. That's it. Okay. Ponte Osteotomy, here the reduction is achieved on a soft disc, a flexible disc. Okay. So when you're bringing the segments, posterior segments together after the osteotomy, the movement is happening at the disc. Okay. The good and easy thing about Ponte Osteotomy is that you can do it at multi levels. You can do it at 3, 4, 5 levels. 1. The other advantage is it is pretty quick. 2. Number 3, you can add this Ponte Osteotomies with different types of osteotomies. For example, you can combine it with PVCR, okay, posterior vertebral column resection and Ponte, which is the most favorite of mine. I'll try to do PVCR at 1 level and Ponte 2 and 2, and then sort of reduce the kyphosis. So with Pontes, as you can see here, the disc is extending, So you have opened the complete, there's nothing in here, all the ligaments and the joint, and then you pull this together over a soft disc, and that is Ponte Osteotomy. So the correction achieved is less, it's just about 10 degrees. Then second, and a little more challenging, is the pedicle substraction osteotomy. Now, what you mean by pedicle substraction osteotomy is that everything that you did in Ponte plus through the pedicles, sorry, you are sort of decancelling the vertebra, and then you are bringing these two together with this V, so you have created this wedge, and then when you bring it together, you're sort of correcting the kyphotic deformity. It is mainly used for Ang-spawn, flat back, and where there has been a decompensation of the kyphosis. So this is another pictorial way. You put in pedicle screws, you do a pedicle subtraction osteotomy, and then you bring them together. So the correction achieved is 30 to 40 degrees per level. So if you want to correct it by 80 degrees, you have to do it at 2 levels. But this is what I want to propagate, and that is posterior vertebral column resection. It's like holding the deformity by the neck and correcting it. So at that point of time, when you have achieved posterior vertebral column resection, you have the whole thing in your hand and you can correct it. Okay, there's nothing holding you to block the correction. So it is the most powerful tool for deformity correction. It was introduced way back in 1920s and 30s, but because of the complications and anterior and posterior approach, it sort of went into disrepute. And then till Professor Suk popularized it through a posterior only approach. And then it was popularized by Lenke for kyphotic correction. And now it has become a very, very important tool in our armamentarium. So VCR basically is done in most stiff curves. The most stiffest of curves you use VCR, because you want to not use it in all or simple cases because the complication rates are higher, and you'll be surprised at the complication rates. So for sharp angulated curves, if there is kyphosis associated with hemivertebra or severe post-traumatic deformities or complete spondyloptosis, you can do it. Now, as this figure shows, this all you remove. So whatever you removed in Ponte is all gone. Whatever you have removed in pedicle subtraction, it's all gone, and the whole entire thing is gone. So practically, to simplify, the disc above, the disc below, the whole vertebra, and part of the attachments of the upper and lower posterior elements as well. So all this is removed. Okay, so there is a lot of osteotomy that is required for this. Okay, so to simplify the steps, you first establish pedicle screws. Fine. So above and below, right? Once you have done that, then very important step is, before you have removed the posterior elements, okay, you just put a rod, you create a rod of the same shape as the deformity. Okay, so if it is bent, there is one rod that is ready, which you can sort of tighten it anytime, which is called the sham rod. Then, then after that, you need to remove all the posterior elements of the levels that you want to undertake. Once you have done that, then you start dissecting from the sides. So generally in my center, we are two neurosurgeons and we do this surgery in tandem. So I am doing from the left and my other neurosurgeon would be doing it from the right. So then after the posterior elements have been removed, we dissect the tissues from the side of the bodies, find the segmental vessels and ligate them. It is also important to ligate, one, to prevent bleeding, and the sort of aorta gets free as well. Then vertebrectomy is achieved. We usually use osteotomes, drills to achieve, and then sort of like I am coming from this side and it's like meeting under the bridge. Okay. So we keep a thin sliver of bone just anterior to the dura. Okay. And the rest of it goes. Once this has been done, the sham rod is tightened, because that sliver of bone is what is now holding the two ends of the two vertebra, okay, above and below. So if I cut that without the sham rod, you can damage the cord because the rod would be hanging, right? So once that is done, then you use the cantilever method. You push in a cage, okay, in the defect, and then with one sham rod, here it is not seen, but then with one sham rod in place, you gradually bring the other rod and sort of tighten it gradually. Okay. So you release the sham rod a bit, you correct the deformity, then release a bit and then correct the deformity. Go slow, discuss with your neurophysiologist that everything is going well. If at any point there is a dip in the motor evoked potentials, wait for time, increase the blood pressure. Then if there is correction, you go on with your corrective maneuver. So as I was talking, the complication rate is pretty high. In Lenke's hand, minor and severe complications total to 40% with a neurological deficit of 12%. These are really high numbers, but the severe complications in the latest of the papers that have been published is somewhere between 5 to 15%. Okay, so which is like still acceptable. In the initial days, in fact, in Professor Suit's hand, he has reported a complication rate of almost 50%, which was very, very high. But still, this has become the most popular because the correction is significant and pretty quick at times. So now I come to my first case, and now I will be showing you a few cases. John, do I have time?
Yes, yes, you do.
Okay, okay. So here, as we saw this, what I did was I combined Ponte and vertebral column resection. And as I was telling you, do not do a lot of shortening. Use SSEPs, MEPs, and from this, we could achieve this, right? Now, what happened was, this is really weak curve, and this we have sort of straightened, almost straightened a paraplegic patient. And this is 6 months later. So he was almost 0 to 1/5. And this we could achieve after around 6 months. So if you choose the patient correctly, if there is some element of power or neurology left, there is a good chance, especially if it is spots and infection, of the patient improving. Now, this is the second case which I had shown of kyphoscoliosis. Again, I would like to emphasize that correction of the kyphotic deformity is more important than scoli. So this looks visually, it distracts us more, but this is what is going to relieve the patient of his or her symptoms. Now, there are certain management pearls you need in all degenerative scolies. In all degenerative scolies, you need a long segment fixation. You need to push it beyond the dorsolumbar junction, okay? As well as try to bring it below into the lumbosacral area as well. Coronal correction is important, but achieving sagittal balance is much more important, as I have told. So here I used 3-level Ponte and I just corrected it. There was some discussion amongst ourselves to use anterior support, but finally we didn't. And this is what we could achieve. This patient has really done well over the last 4 to 5 years of follow-up with us. Now, this is another girl. She's just a 10-year-old girl with progressively increasing hump in the dorsolumbar region. Okay, and almost 2 bodies are totally destroyed. There is paraparesis with the power of 4/5, Cobb's angle of 60 degrees. So 60 degrees now, it's not going to heal. Rather, even after healing, the kyphosis would progressively increase. This was her MRI, again with an active disease and with a lot of neurological compromise and compression to the cord. So here we did 2-level vertebral column resection. Now, 2-level vertebral column resection, you really need to do it quick because there would be good amount of blood loss, okay? And also you require a long cage. Now, just imagine you have lumbar roots coming, L1. You can't sacrifice L1. You can't sacrifice L2 roots, okay? So pushing it a long cage in itself is a challenge, okay? So what do we do as far as pushing the cage is concerned, okay? Now, this is an excellent paper by Hunt and Shen, and this technique is called as Hunt-Shen-Arlett technique. We are very fond of this technique and we use it. It is a very, very simple technique. There's nothing fancy other than the name of this technique. And what they told us to do is you just tie these sutures at both ends of the cage. They have used expandable. I generally tend to use non-expandable cages. Only in a few cases or limited number of cases, I would go in for an expandable cage. Though these days, there's better technology to open these cages. So just understand here, these are the bared roots, the naked roots here. And I have to push the cage from here to here and in such a fashion that this root does not get damaged. So what they have suggested is just pass a thread below the root, push this anterior, and then you pull it. Once you've pulled it, you have area to sort of impact the cage inside. Okay, so I'll just show you a quick video here. Here we have put in the pedicle screw. We are doing the vertebral column resection, and after all these elements are removed, here you will see the root. It will just be appreciated. Okay, yeah. So here you see the root. Fine. This root we need to preserve. And so a thread, cage tied with the thread sort of goes under the root. Fine. And you simply, we have used Vicryl because what we do is we just tend to cut it near it and then we leave it there. So finally you straighten the cage, gradually push from one side and pull from the inferior side. Okay. And at one point of time, once it is snuggled in, you can just impact and then confirm on your C-arm. And if you're using an expandable cage, you can just expand it. Okay, so this is what we could achieve. There is good inflection point somewhere here. This is a bit of thoracic kyphosis, and here we are getting lumbar lordosis, and this is the long cage that we had introduced in this patient. This is the AP view. Another lady, 28-year-old, dorsolumbar pain, not able to walk for 1 month, single level with some destruction of the lower vertebra, a gibbus and a Cobb's of 55 degrees, severe compression as you can appreciate on CT. Again, severe compression of the granulation and perhaps pus. And again, PVCR with an expandable cage, and this is what we could achieve here. Okay, another lady, yes, this is an interesting case. A lady in her 3rd decade who had low back pain with severe radiation. She underwent a hysterectomy for this pain. And when her pain was not resolved and she started developing neurological symptoms, she was sort of investigated, and there was complete destruction of L5, and there was a local hump, L4 over S1. So the L5 body was destroyed and there was compression. Now, this case is important because what I want to tell you is that in such a situation, you need to really balance it and get your construct low into the sacrum and the ilium. So here we did a posterior approach again, anterior cage placement, and then we fixed right from L2 to S2 and into the LR through the S2 LR iliac screws. I am not very fond of the iliac screws. I love this S2 LR iliac screws because the screw heads are in the same line. You don't need connectors, and sort of you are able to do this placement pretty fast. So I love the S2 LR iliac screws, and this is what was achieved post-operatively. Okay. Now, last case perhaps is a case of iatrogenic kyphoscoliosis. This 16-year-old boy, he was operated about 1.5 years back when a long segment laminectomy was undertaken when he was 15, and he was operated for an intramedullary tumor. It turned out to be astrocytoma grade 1. That is what we saw the reports. However, after a year, he again started developing symptoms of lower limb weakness. He came to us with recurrence and a power of 1/5. Now, here the challenges were very different. Here, the tumor was sort of the upper end of the laminectomy mainly. However, the scoli and kyphosis was lower down. So the tumor was somewhere here, and we needed to correct the deformity lower down. So there again, for the newbies, there are certain specific terms that we use when we are correcting the scoli, like the upper end vertebra, the lower end vertebra, the apical vertebra, the concavity, the convexity, the upper instrumented vertebra and the lower instrumented vertebra. These are certain technical terms that you will be sort of, when you'll go into scoli, you will come across these terms very frequently. Now, here the challenges for us were very different. One, young patient with deformity, though it was supple, which we were very lucky, and intramedullary tumor with severe weakness. Okay. So here the biggest challenge for us was to preserve the motion segment in case if he regained his power in the future, and to correct obviously the deformity. So here what we did was we found that L3-4 disc and vertebra, we could push the fixation up, and we took the fixation up, and then we sort of fused from D6 to L3, and we corrected the coronal and the sagittal imbalance after excision of the tumor. So coming to my take-home message for complex deformity, especially kyphosis, posterior-only approach is the current way to go. It is the most popular approach. It is perhaps the easiest to learn as well. try to use a combination of osteotomies. Do use Ponte. It is very easy. We do a lot of laminectomies and we injure a lot of facets as well. So it is perhaps easier for us to go. Then Hunt's technique, as I've shown, is an excellent technique to push in the cage. You can achieve good to excellent outcomes even in the most of difficult cases. You will get a lot of cases of quad spine wherein you should attempt this surgery. Gradually, you will develop technical expertise, and you should have, ideally, you should have IUNM and a person trained, which is perhaps the most difficult part of this whole gamut. Definitely, that will help reduce complications, medico-legal issues, and you can achieve a lot more correction if you have an IUNM with you. Thank you so much for your patient sharing.
Okay, let me unmute here. I'm always caught by surprise. Yeah, thank you very much. Very detailed, excellent presentation. First, I'd like to get comments from Dr. Goel. I saw he was here. Let me see if he's still here. Are you there, Dr. Goel?
Yes, John, very much.
Okay, could you please comment?
Yes, Ashish, that was absolutely, I'm so happy and really proud to hear your absolute professor-like presentation. And there is no question what you were saying, with the confidence you were saying, and with the conviction that you were saying, with your experience. You are really a fantastic teacher. And I'm sure we have to see much more of you in the coming times. As far as this surgery is concerned, of these deformities, I must say that I see deformities related to other issues, like related to craniovertebral junction, cervical kyphosis, kyphoscoliosis, related to syringomyelia. But these kind of kyphosis that you are talking about, low lumbar and lumbosacral kyphoscoliosis, and these kind of pelvic incidents, that all these things that you were talking about, I don't do much. But what I was concerned about is the complication rate that you were mentioning. I thought that complication rate, if 50% complication and 40% complication and 20% complication rate, I think then this complication rate of this surgery is much too high for giving any kind of confidence level to the patient and to the relatives. What do you have to say about this, Ashish?
Yes, sir, absolutely correct, sir. And sir, when these have been reported by Professor Suk, Professor Lenke, who are like like you, sir, done so many cases day in and day out, they are operating, and if they are reporting such high numbers, so in that regard, I have to say two things. First, that complication has come down. The recent papers now suggest a complication rate somewhere between 10 to 15%. But I wanted to emphasize that in my presentation here, especially for the youngsters, is do not take this surgery easily. You need to sort of learn it and be very cautious. Also, do not go for an overzealous correction. It's something like, sir, what you all have taught us. When petroclival tumors came and when the skull base approaches came, the whole aim was to excise it completely. And we had so many complications. And then gradually we were taught by you and so many of our mentors that, look, even if you leave some tumor, but the patient should be intact. And that we have learned that, you know, you don't need a picture perfect pillar and column type of a structure in spine, which is deformed. You just need to make the patient sort of pain-free, better neurology. And then third is cosmesis.
Yeah, I can understand that. I can really understand that. And I will invite you to read one of my articles on kyphoscoliosis, which was recently published. And I related it to craniovertebral instability. And craniovertebral stabilization led to reduction of kyphoscoliosis. I think it is a must-read article for you, Ashish.
Sure, sir. Well, I can see there are a lot of participants here. And to all the residents, I would like to tell you that you should read what Professor Goyal has written. You must read again, especially things on CVJ. I'm talking about spine, craniovertebral junction. Please read each and every word that he has written. Please go through whatever he says for CVJ, because I'll tell you my experience. I started CVJ, transoral, posterior. At that time, Professor Goyal had already given his distraction technique. I didn't use it. I was not taught. Then a little bit of transarticular screws, then anterior approach. Finally, after all the jugglery, I am absolutely sure in my mind that posterior approach is the way to go, number one. Distraction is what is very important, both for correction of BI, for AAD. So I would not like to say, repeat what he always says, but please read each and every word that he has written or presented. For all the residents, please go through that.
Ashish, another question I want to ask you.
Sir.
What is the role for distraction in reduction of this kyphoscoliosis? Is there any role for distraction?
Sir, basically distraction comes in use when you are doing, say, traumatic kyphotic deformity, wherein, you first need to bring the bone which has got impacted. There, you need to first distract. Otherwise, generally, it is more of osteotomizing the things and reduction. And in fact, the neurological damage also happens, sir, when you're reducing the neural elements a lot. So that is where we have been using distraction a bit.
Ashish, there is one question from Dr. Lewis. He is asking about the sacrifice of the nerve roots, or do you try to conserve the nerve roots? What do you have to say about that?
Well, we need to conserve the nerve roots. We need to conserve each and every root. Again, coming back to, see, lumbar roots, each and every lumbar root is important. You sacrifice one lumbar root, the patient will never forgive you for the deficit you have created. Okay. Again, coming to CVJ, when Professor Goyal started, I'm sorry, sir, I'm using your words time and again. When Professor Goyal started CVJ, he used to sacrifice C2, and now he doesn't. Now C2 just gives sensation in the occiput region, but that itself is important. So just imagine the importance of the roots, especially in the lumbar area. Now, the only roots that you can sacrifice are the lumbar roots. Okay, sorry, the dorsal roots, and that too only on one side, one level. So you can't just keep on cutting even the dorsal roots more than one on one side.
Yeah. Another question that has been asked is bleeding and cord ischemia. Should we consider this point during osteotomies at thoracic level?
Oh, bleeding, yeah, why not? Sorry, sir.
That may be the key to success, right? To avoid ischemia.
Oh, yes, absolutely. So, see, you need to, in our center, what we have been doing is that under no circumstances does our mean arterial pressure in a normotensive patient comes below 68 to 70. So because these are long surgeries, prone position, so the blood pressure, the mean blood pressure, we don't bring beneath 65, 68. But similarly, in a normotensive patient, we request our anesthetist to keep the mean between 68 to 72. That's number one. All our patients receive Trenexa, so or prior to surgery. That's number two. Number three, we are very particular about hemostasis while we are doing at a particular level. So what I mean by that is, suppose there's one more rule which I haven't discussed, which is more related to scoliosis, is that put the concave screws first. Okay, so in scoli, we need to dissect the muscles from both the sides. Okay, Like suppose if I am doing just trauma, I'll expose only one side, put the screws, then expose the other side, put the screws. But in scoli, because you need to release, you need to dissect both sides simultaneously. But try to put screws from one side, try and avoid as much oozing as is possible. As far as ischemia is concerned, yes, definitely, cord. You do not want to get a bad result. Lot of bleeding with lot of implants, lot of hematoma is sure shot, phenomena for infection. Why do you want that? Okay. And similarly, ischemia, these neural structures are already compromised. You can't compromise them any further.
Another question is from Dr. Saurabh. He is asking if there is nothing during the operation, intraoperative monitoring was okay, but the patient lands up with paraparesis. How do you approach such a case? That is quite a good question, Ashish.
Yeah. Okay. Now, see, no findings on intra-op monitoring with post-op paresis. Generally, we have the reverse, which is true, wherein the IONM shows a deficit, but the patient comes out normal, especially once the IONM has corrected. The other way is there are two. Either your neurophysiologist has missed, that is one thing, or the patient already had severe weakness in those group of muscles. However, having said that, if the patient comes out worse, unexpectedly, please do as we do for any spinal case. Okay, look for an epidural hematoma, look for any collection. There is a possibility that you have overcorrected many a times, or I would say the master suggests that you may have to go in quickly and sort of release the pressure, or overcorrection that has been undertaken. So you need to do that, and you need to do that pretty quickly unless your patient is improving fast.
Another smallish question is, how do you prevent neural injury and paraplegia kind of sequelae? How do you prevent? What are your key steps?
Okay. Avoid paraplegic sequelae. Sequelae means once the patient has come paraplegic to us, or?
No. How to avoid neurological worsening.
Oh, okay, fine. So as I've already told you that you need to release the neurological elements first. That is surgery number one. So after you've done the dissection, you do the decompression. So you just put in the screws and you do the decompression. By decompression, what I mean is the cord as well as the roots. That is very important, especially where the maneuvers are going to happen. That is extremely important. Number two, whenever you are correcting, just understand that there is shortening of the neural elements that is happening, especially in correction of kyphosis. So the minute you have IONM changes, then you sort of stop it till it's absolutely corrected. If it is not corrected, please do not move ahead with the surgery. Okay, rather release the correction a bit. Okay, and then see. Number two. Number three, as we know, whenever IONM goes, you talk to your anesthetist, you increase the blood pressure, you wait patiently. You may also do some warm saline irrigation, okay, the temperature. So this is next thing that you undertake. So these are the basic steps. Also pre-operatively, while you are planning, you need to understand, and I'm emphasizing this time and again, that do not be overzealous for correction. Okay, there are certain rigid curves and there are certain supple curves. So supple curves will get corrected easily, whereas rigid curves you will have to really struggle. But don't sort of break it.
Well, Ashish, there is another last question. What about pain in the region of cut nerves? When you cut the nerves, what happens? Is there pain a problem, or numbness a problem, or what in thoracic roots?
Oh yeah, as with any nerve root, you will have The patient will have, may have pain, may have dysesthesia, may have paresthesias. Now, when you cut a single root, we know that with time, you know, with the changes that happen in the neurological system, you know, part of it will reduce. But when you cut two, there will be a fixed area of paresthesias and numbness or dysesthesias, which can be really difficult to manage, and or severe burning sensation which the patient will have.
Yeah.
Again, here I would like to emphasize that, you know, again, coming back to CVJ, if you have to sacrifice the root, just try and sacrifice one. Don't sacrifice both. This is again what Professor Goyal sir teaches us.
Yeah, Ashish, very nice presentation. Congratulations to you. And I will have to now follow your work more closely because you are a fantastic, confident, and absolutely professor-like attitude. Thank you and congratulations for your wonderful, wonderful teaching presentation. I'm sure the young people present in the audience will have really learned some nice bits from you. Thank you very much, Ashish.
We are extremely thankful to what you have taught us, sir. I have learned a lot from you, and we all, the whole neurosurgical community is indebted to you, your vision, and to the help you provide us, and especially for your love for Jabalpur. You've been coming here. Thank you so much, sir. Thank you for your work.
Thank you. Bye-bye. Good night.
Yeah, Dr. Goel, when Dr. Goel shows up, the numbers go up of the viewers. So it's always good to see him come here because I know the numbers are going to go up. And does anybody have anything they want to introduce themselves to Dr. Goel or Ashish? Anybody in the audience that would like to say hi and take the opportunity? If not,
Yeah,
now you can always make the. Go ahead. Go ahead.
I think Jitin had one question.
Okay.
Dr. Jitin is from Jabalpur. He is a very young and dynamic neurosurgeon who's into academics and he's into epilepsy work. His question is, are the indications and principles of surgery similar for POTS and idiopathic kyphosis? Well, there is a difference. See, in idiopathic kyphosis, you do not have an element which needs to be decompressed or excised. There is in POTS, because you want to reduce the infective element or the bacteria, you try to decompress as much as possible, as much as safely you can remove. Whereas in idiopathic kyphosis, you don't need to excise anything. You just need to correct the. So that is the biggest difference between POTS infection versus idiopathic kyphosis.
Okay. Okay. Very good. Let me get on the screen here. I'm a little off there. Okay, very good. Any closing comments anybody wants to say or weigh in? Okay, well, great. Thank you very much. We look forward to your next presentation, Ashish. And,
thank you so much, sir. Thank you. And thank you, everybody, for joining us. Thank you.
Okay, we'll end this now. Thank you.